I'm now going to get into conditions of the young adult. Again, these are not exhaustive, but some common things that you're going to see. Muscular low back pain, far and away the most common thing that will present to GPs, to physios, to chiropractors, to osteopaths, to you in a sports medicine clinic. It's extremely common. I'll talk a bit about lumbar disc herniation and lumbar radiculopathy, and then go into the more severe form of Cauda Equina syndrome, and then also talk about inflammatory arthropathies such as Ankylosing spondylitis, which often initially present in young adulthood and then progress throughout life. So mechanical or muscular low back pain. It is a wide-ranging catchment of things that we have many muscles in our back. We have multiple facet joints. We have multiple ligaments throughout the spine that can all undergo an injury for various reasons, either through sporting events, work, just being out of shape and doing something that your body's not used to, can all present with back pain. The prognosis for this tends to be very good. It's typically short-lived pain for 4 to 6 weeks. The patient will be able to get back to their activities. And the worst thing they can do is have prolonged rest. You want to get these patients up and active, doing things, making sure that they're not just lying in bed, lying on the couch, doing nothing, and decompensating. Of course, we do need to rule out other things that go along with this. You want to make sure that they're not having a lumbar disc herniation causing radiculopathy. If they have ongoing pain longer than 6 weeks, you have to start investigating for other things such as ankylosing spondylitis, other disease processes of the spine. Have they had a subtle compression fracture due to a fall or something like that? But again, most of these patients will have a significant amount of relief within the first few weeks. Certainly on examination, you're going to want to rule out any radicular findings. And really the mainstay for investigations is that in the early stages of back pain, don't do anything. I know that sounds a bit ridiculous in some ways, but an x-ray isn't going to change your management. A CT and MRI certainly aren't. I would only recommend further imaging if you start to get some red flags, altered history, prolonged history, altered physical findings. That's when you start to investigate. Routine back pain should not have an x-ray, should not have a CT scan, should not have an MRI. And the management should focus on conservative therapies from light activity, hydrotherapy, physiotherapy. You can try things like acupuncture, massage, and then short courses of oral pain medications, simple anti-inflammatories. If they're having severe muscle spasm, you can think of the antispasmodics, things like that. But again, you want to be doing short courses and avoiding narcotics as much as possible due to all the side effects of narcotics. I've just put up a couple pictures of all the things that potentially can cause low back pain. There's certainly a wide-ranging presentations of how low back pain presents to us, and it's common throughout the world. And this leads into lumbar disc herniation and lumbar radiculopathy. These patients typically present with acute pain that starts in the low back and radiates down their leg. For low lumbar, L4-5, L5-S1, it's going to radiate down the posterior aspect of the buttock and leg and into the lateral calf and foot. For patients that have, say, an L2-3 or potentially an L3-4 disc herniation, it may present a little bit differently, possibly going down the lateral thigh or the anterior thigh, depending on which nerve root is affected. Remember, typically for most central or paracentral disc herniations, the nerve root is affected that transverses the disc because say it's an L4-5 disc. By the time you get to the L4-5 disc, the L4 nerve root has already exited through the foramen, so it's going to be the L5 nerve root that's affected. If it's a far lateral disc, it may be hitting the nerve root that has exited through the foramen, so that might hit the L4 nerve root. And that's where your further imaging like an MRI is going to be helpful, and having an understanding of anatomy and neuroanatomy of where the normal muscular and dermatomal distribution of each nerve root is really important in assessing these patients. How it happens is you get a tear in the annulus fibrosus, the nucleus pulposus herniates out. Now remember, on development, the nucleus pulposus is largely avascular. So in the developing immune system, the immune system has never seen the nucleus pulposus, so it sees it as foreign material, which creates a massive inflammatory reaction. And that's what causes a great deal of the pain early on in the process. It's not necessarily the mass effect of the disc, as is the inflammatory reaction around that nerve root. And that's where some of the evidence for epidural steroids does have some support in that acute phase of pain. Certainly oral steroids, a short course of 4 to 5 days would be very reasonable, or trying an epidural steroid. The injections have variable success in studies, I think largely due to when they are administered. That it's that acute phase, that acute inflammatory phase when the immune system is first seeing that nucleus pulposus, where people get a great deal of pain and potentially a great deal of relief from steroids. Who get disc herniations? The traditional theory has been laborers, that it's the guy moving your fridge, it's the person moving the couch, or the professional athlete that's gets a disc herniation. While that does happen if you have a bad fall or have a bad injury, it seems to be genetically predisposed individuals. There are some really good twin studies out of Europe from a little over 10 years ago that showed the majority of disc disease and disc herniations occur due to genetic factors rather than physical factors. So just like there are people that are predisposed to getting hip arthritis, knee arthritis, thyroid cancer, breast cancer, there are people who are genetically predisposed to having disc herniations. So it's not just the overweight laborer that gets a disc herniation. Mainstay of diagnosis, of course, is going to be your physical exam assessing for radiculopathy, so straight leg raise. If it's a upper lumbar disc herniation, looking for the femoral stretch test, so rolling them over prone, or getting the leg lying over the bed and stretching the femoral nerve rather than the sciatic nerve, if it's a upper lumbar nerve root. Of course, if it's a thoracic disc herniation, you're going to be looking for signs of myelopathy, because it's typically not nerve roots, it's actually the spinal cord. So looking for unsteady gait, inability to do tandem gait, hyperreflexia. Those are things you're going to look for in terms of myelopathy of the thoracic spine. Mainstay for diagnosis is going to be MRI. CT scan can be used, but it doesn't give us nearly the quality of picture that an MRI does to assess the disc herniation. Management, early acute management, anti-inflammatories, potential use for steroids. When is surgery indicated? It's a really good question. That the natural history for a disc herniation is it will get better. And if you look at surgical versus non-surgical trials, if you follow these patients out long enough, the groups come together. That after about 3 years, the outcomes of surgical versus non-surgical management are about the same. What surgery does is get people back to work and back to life more quickly. That if they've had symptoms for 4 to 6 weeks, things aren't getting better, and they're really struggling with pain and unable to get back to their activities of daily living, then surgery is very reasonable. Will patients need surgery? Not necessarily. The patients who don't want to have surgical intervention, it's not essential unless we're dealing with something like Cauda Equina syndrome, which we'll talk about next. That many disc herniations will settle down on their own. It just needs time. And the question is whether or not the patient's willing to give it that time. The difficult part, of course, in the Canadian public sector is waiting lists are long, and so getting to these patients in a timely fashion is a bit more difficult. And that's one of the difficulties of dealing with long waiting lists. It's also one of the benefits is because it forces patients to take the time to get better on their own, as many of them will. The next slide just shows a couple examples. That's a paracentral disc herniation causing irritation of the L4 nerve root. Excuse me. On the left-hand side. And so this will likely cause pain in more of the lateral thigh and lateral calf, potentially lateral foot as well, rather than the traditional posterior sciatic pain. That they may have some of that the L4 nerve root does have some contribution to the sciatic nerve, but it might not be the prototypical pain that goes down all the way into the big toes that you think of with an L5 nerve root radiculopathy. Cauda Equina syndrome is prototypically caused by a large disc herniation. Anything causing mass effect to the Cauda Equina, or the lumbar canal, can cause Cauda equina syndrome. So tumors can cause it, infection can cause it, a fracture can cause it. Anything that compresses the Cauda equina and all the nerve roots within. The key components to this are patients going to have typically bilateral pain and pain that really is quite severe. Now, radiculopathy can be quite severe. Cauda equina is typically extremely severe, and they're typically printed into the emergency department. The hallmark as well is going to be paresthesias within the groin or perineum, potentially urinary incontinence, and this is a surgical emergency. If you have someone that you think has Cauda equina syndrome, get them to the emergency room as fast as you can, whether that's through an ambulance or whatever you need to do to get them to see a spine surgeon ASAP. That the longer these symptoms persist, the greater likelihood that patients will have permanent neurologic disability, and particularly bowel and bladder lasting effects is significant. So we want to get to these patients as fast as possible. MRI is very useful in terms of us localizing where the lesion is and determining what the cause of the problem is. So that'll be kind of the emergency management of getting a patient an MRI and then getting the patient into surgery. And really, I can't emphasize enough how important it is to get to these patients quickly. The next MRI just shows another disc herniation. It's a larger disc herniation causing increased compression of the thecal sac. Again, the MRI does not diagnose Cauda equina. Cauda equina is a clinical diagnosis. What we're doing with the imaging is localizing the lesion. That I certainly have some patients on MRI that I think, jeepers, that's a massive disc, that must cause Cauda equina, but it doesn't. Other patients where I look at the MRI and say, I'm not as impressed, but the patient's clinical scenario is clearly Cauda equina syndrome, and thus it's a surgical emergency. The next slide is talking about inflammatory arthropathies of the spine, spondyloarthropathies. Prototypical would be ankylosing spondylitis. DISH, or diffuse idiopathic skeletal hyperostosis, is another disease process that's a little bit different than ankylosing spondylitis. And of course, other disease processes can also affect the spine. Rheumatoid arthritis can affect psoriatic arthritis, although it's much less common. Any inflammatory arthropathy can affect the facet joints. They are synovial joints. They can be affected by this. Ankylosing spondylitis, of course, also affects the ALL and PLL, and is an enthesopathy, creating ankylosis of the spine. It often presents early on in the 20s and 30s with low back pain, sacroiliac joint pain due to inflammation in these regions, and progressive over time causes loss of mobility. The key will be looking at patients' loss of lumbar lordosis, loss of mobility of their lumbar spine, and then getting blood work to look for inflammatory markers, ESR-CRP, HLA-B27 association, and then potentially also looking for carrot stick fractures due to osteoporosis and a very stiff spine later on in life. It's quite a broad condition that, again, it's definitely worthwhile going into more detail about understanding ankylosing spondylitis, understanding DISH, and the differences between the two on X-ray. Early on in the disease process, the mainstay of treatment will be rheumatologic, anti-inflammatories, and disease-modifying agents. And then as the disease progresses and causes potentially stenosis and abnormal balance within the spine, then surgery plays more of a role. And surgery in these patients is extremely complex due to the stiffness of the spine as well as the osteopenia that's also associated with it. The next slide just shows an example of that bamboo spine of ankylosing spondylitis, as well as some pictures of normal posture versus the typical posture of someone with ankylosing spondylitis, the flexed hips, the loss of lumbar lordosis, positive sagittal balance. Remember that ankylosing spondylitis can also affect the hips quite significantly, and so they get very limited mobility and very limited ability to compensate for the deformities that develop. Sacroiliac joint dysfunction can be part of the early presentation of ankylosing spondylitis. That's one of the first joints that it does affect. But many patients can get mechanical pain in the sacroiliac joint region. Certainly it's prototypical in pregnancy and post-pregnancy due to the ligamentous laxity and the changes to the pelvis that come with pregnancy and delivery. But it's certainly not isolated to these areas. That it can sometimes be very difficult to differentiate from muscular low back pain or L5-S1 discogenic pain. Things that will help will be that it is very mechanical in nature, tends to occur more with heel strike, and then on physical examination, doing what's called the Faber test, or flexion, abduction, and external rotation of the hip, and then contralateral pressure on the iliac crest to put stress to the SI joint. And if patients experience pain in their posterior pelvis with that, then likely a potential cause of their pain. Different things that you can be looking for, of course, looking for ankylosing spondylitis, blood work, MRI, workup for that can be potentially be helpful. And then really the mainstay of therapy is going to be working on physiotherapy, working their core, working on their pelvic floor, getting that rehabilitated will be mainstays. Bracing can help. Mobility support such as crutches, cane, walker, potentially can be helpful, particularly during pregnancy if they're having a great deal of trouble there. Surgery should be a very, very last resort. The role for corticosteroid injections into the SI joint and radiofrequency ablation is more controversial. That the SI joint is not a prototypical synovial joint. It is a joint of fiber cartilage, not hyaline cartilage, and thus the role for cortisone is less clear, but certainly does seem to be effective for some people. Prolotherapy has become all the rage in some circles, and again, that's highly controversial, and I can't really support that from an evidence-based point of view. The next slide just goes through some of the anatomy of the sacroiliac joint. Remember, the sacroiliac joint is an extremely stable joint. It requires a great deal of trauma to disrupt the sacroiliac joint. There can be some mild instability, if you want to call it, a bit of mild motion that can potentially cause pain because there are very substantial ligaments and muscles around the sacroiliac joint. But to call it true instability, I think, is a misnomer, as true instability would be the loss of normal physiologic anatomy during walking, which tends not to occur. The next thing that we'll talk about is transverse process fracture, transverse process fractures. That, again, different etiology. This is a fracture. It's trauma, and usually mild to moderate trauma that can occur anywhere in the spine. It can be associated with rib fractures in the thoracic spine because the ribs passerate anterior to the transverse processes. So with significant chest trauma, you can get a transverse process fracture that can cause back pain. In the lumbar spine, of course, your microstabilizers and part of the paraspinal complex will attach to the transverse process fracture. So a forced lateral bend combined with flexion or extension may cause subtle fractures of the transverse processes. These can be very difficult to pick up on X-ray. They can be seen on CT and are usually picked up on CT scan when patients getting an abdominal CT to look for any intra-abdominal trauma. Most of these will cause back pain for 4 to 6 weeks, and as they settle down will improve. This is not an unstable fracture typically of the spine. Ones to watch out for are transverse process fractures of L5. In patients with unstable pelvic injuries, when one half of the pelvis shifts up or down, that potentially can cause a fracture of the L5 transverse process fracture. So In a patient in high energy trauma, when you see an L5 transverse process fracture, you do need to rule out any evidence of pelvic instability, as that can be a major potential cause of significant intrapelvic bleeding and may require surgical stabilization. Most of these patients will do well with a combination of time, some short-term of rest, anti-inflammatory medications, and then physio and rehabilitation once the pain is settled down. Bracing can be used as a form of pain control, but as these are not typically unstable fractures, bracing is not required. It's really just another form of pain control if the patient doesn't like taking medications and has pain with standing up. We've included a video of soccer players that it's amazing how much trauma can occur with absolutely no contact, and then getting some small fractures that they're usually relatively undisplaced and do not represent instability to the spine.